Welcome to chapter 16 of Intro to Psychology. In this video, we're going to be discussing various types of treatment for depression specifically. So you'll remember from the beginning of the semester that we talked about 7 perspectives in psychology, 7 different ways of approaching basic scientific questions in psychology. And this most importantly applies to the field of psychotherapy, of providing a therapeutic intervention for people with psychological disorders. So we're going to begin by exploring biological treatments for psychological disorders. And for the sake of being concise, I'm only going to talk about treatments for depression. There are many different forms of treatments for all kinds of different disorders, and I'll provide some links so that you can explore that. But in these videos, I'm just going to describe treatments for depression because depression is such a high base rate psychological disorder. It's one of the most common disorders out there. So some examples of biological treatments for depression include medication. Many different forms of medication are used to treat depression. One such form of medication for depression is called SSRIs, selective serotonin reuptake inhibitors. We discussed this in an earlier chapter this semester. So for example, people who take Prozac use it to enact some changes at a biological level, at the level of the neuron, with the hope of improving symptoms of depression. Some studies have shown that depressed individuals have low levels of serotonin in their cerebral bloodstream. And what SSRIs do is they block the reuptake of serotonin. So they block the recycling of serotonin. So here in this diagram where it says neurotransmitter, that can be thought of as a serotonin neurotransmitter that goes to a postsynaptic cell to enact some kind of positive feelings, to give a simplistic example. And then after it does its action here at the receptor, it is then goes through the process of reuptake, going back into the vesicle to be used again for the next time that neuron is active. What SSRIs do is they block the reuptake of serotonin, so that serotonin has to chill here in the synaptic cleft, and it elongates the effect of having this positive neurotransmitter, so that people can, hypothetically speaking, can feel happier for longer, or can increase the induced happiness of serotonin. The next one unsolved mystery regarding SSRIs is the delay between the action of SSRIs on a biological level and symptom relief on a psychological level. There's a noticeable delay in the time between a person starts taking the drug and the time when they start to feel better. It usually takes several weeks for someone to be on Prozac before they actually start to experience symptom relief, even though the biological mechanisms start immediately. We also know that about 40% of individuals who use antidepressants become treatment resistant. And also that there are so many side effects of medication use, such as weight gain and others. And so in conclusion, we know that biological mechanisms such as SSRIs aren't the only things that contribute to someone's depression. Other alternatives besides medication is using aerobic exercise. We know that any exercise that targets improving the circulation of oxygen throughout the body, particularly the brain, can really help with all kinds of psychological disorders, including depression. Particularly exercises that challenge spatial awareness, balance, and motor coordination are really effective for helping people improve people's mood, as well as improving people's memory and other aspects of cognitive functioning. But we do know, however, that even elite athletes, people who do a lot of exercise, can still experience depression. And so once again, the biological aspects or the biological things that are going on to produce feelings of depression do not explain everything there is to know about the genesis and the treatment of improving symptoms of depression. There's probably more that goes on a psychological level. Other treatments for depression that I'll briefly mention are TMS, transcranial magnetic stimulation, and ECT, electroconvulsive therapy, two types of devices that can be used to alleviate severe forms of depression. And I've included some videos on our Canvas page for you to explore those in more detail. Next, exploring some cognitive treatments for depression. So once again, when we say cognitive, we're talking about thinking. So cognitive treatments for depression focus on changing how people think. The belief is that how you think determines how you feel. If you have negative ways of thinking, then you will feel negatively. So for example, if someone fails a test, and their internal beliefs are that, or their internal thoughts are that they feel that I'm worthless and I'm stupid, that those kinds of negative and unhelpful thoughts can lead to depression, versus interpreting the event of failing a test in a different way, saying, I'm smart, but I didn't study well for this test. Those individuals would be less likely to experience depression. So the idea here is that by engaging certain cognitive strategies, you can help mitigate the effects of depression. Cognitive therapy was pioneered by Aaron Beck, who used the diathesis stress model of depression and stated that essentially people have a cognitive vulnerability. Some people have personality factors or other ways of negative ways of thinking that are just, they're naturally developed, that when combined with a stressful life event can lead to depression. And so he theorized that these depression prone people have certain depressive schemas, certain depressive ways of thinking, certain cognitive biases that make them focus on the negative aspects of life rather than the positive ones, and interpret situations as negative in a consistent way. One of the things that he pioneered was the cognitive triad, that people with depression have negative views about the world, negative views about themselves, as well as negative views about the future. And so they think that the world is fundamentally wrong, and that their future is fundamentally doomed, and that they themselves are fundamentally imperfect and flawed. And so those three things together create this kind of depressive environment where every situation is interpreted negatively. So, for example, a person like Danielle in the vignette that we saw before might feel like, you know what, the world is against me. My teammates don't like me, and might think about the future as I'll never get to play as much as I used to, and might think about themselves as I'm a total loser. And so the therapist's job in that situation would be to uncover the automatic thoughts that are leading Danielle to make those attributions and to think those thoughts, and expose them and show how they're not always true. Another aspect of cognitive therapy is to help clients become more aware of their cognitive distortions, their errors in thinking. So overgeneralizing, taking a small situation and making it bigger than it actually is. Polarized black and white thinking, seeing things in absolutes. I'm either perfect or I'm a complete failure. Or jumping to conclusions, assuming that people are thinking negatively about you or reacting negatively about you without much evidence. Many individuals struggle with this, with getting caught and thinking about what other people are thinking about them. And really, the further you go down that track, the more likely you are to develop depressive ways of thinking. So that's really the pure cognitive approach to psychotherapy. Next is the humanistic approach to psychotherapy, which we described in earlier chapters, which is centered around the belief that depression and other forms of psychological disorders result from an inconsistency between a patient's behavior and their true personal identity. And so the psychotherapist in this situation helps create a comfortable interpersonal environment that's less focused on changing negative thoughts and more focused on affirming the client and helping them feel comfortable in exploring their own goals and identities. The pioneer of person-centered therapy, or also known as client-centered therapy, was Carl Rogers, and he employed certain well-known techniques that were very influential in psychotherapy in order to help individuals with their cognitive difficulties or their emotional difficulties. Things like being non-directive, not letting the client take the lead in the therapy session and not telling them what to do. Things like active listening, acknowledging what the client is saying, and restating it and clarifying what the client is saying in your own words as a therapist, and using an unconditional positive regard, refraining from any form of judgment, really creating a warm and affirming personal environment. Rogers called this therapeutic technique person-centered therapy or client-centered therapy, as opposed to cognitive centered, where the focus is on the thoughts or on the disorder or on the negative, because he really felt like the term, those other terms, or particularly the term patient, suggested that the person was fundamentally broken, or the person was fundamentally looking for a cure. And so this was a very influential form of psychotherapy, particularly in the 20th century. Next is psychoanalysis. So this is, as we've described in earlier chapters, founded on the notion that unconscious desires and unresolved conflicts, perhaps from childhood, is the main source of mental illness and psychological disorders. And this was pioneered by the work of Sigmund Freud, who was the Austrian neurologist who was fascinated by patients who suffered from hysteria. We described hysteria last week. And theorized that many of his patients' problems arose from some unresolved conflicts in the unconscious mind. So different than cognitive therapy, where the emphasis is on conscious experiences and conscious thoughts. He emphasized examining unconscious and automatic thoughts. And so part of his conceptualization was that there are these basic three aspects of the human psyche: the superego, the ego, and the id. So the id was kind of this, the lowest level of cognition, just a pleasure-driven, unconscious sexual and other urges. And then at the top was the superego, which is kind of the conscious and human and moral and socially acceptable aspect of a person's mind. And what Freud conceptualized was that the id and the superego were constantly at war, that they were that there was a constant war between being socially acceptable and having, giving into your urges. And the thing navigating this war was something called the ego. People were encouraged to develop their ego and develop a balance between giving in to urges and being socially acceptable. And his ideas were very prominent and powerful in the early development of psychotherapy. Psychoanalysis was perhaps the first organized form of psychotherapy. And he used many techniques to try to test out his concepts, such as free association, having the patient relax and say whatever comes to their mind, examining patients' dreams, as well as examining transference, examining any ideas that the client would express that towards the therapist that might represent someone in their real life, or that they would transfer to the therapist. They often also used a couch where the therapist or the analyst was seated outside of the view of the patient, so that the patient's mind would not be influenced by the facial reactions or the any other behaviors of the therapist, and that they could kind of freely associate with whatever was going on in their subconscious mind. And this is a technique that isn't used as frequently today. The modern form of psychoanalysis is called psychodynamic therapy. And as we described previously, many of the ideas that Freud came up with don't have much research support. We don't have much research evidence that there are necessarily these three elements of the human psyche that he described. But many of the ideas that he brought forward have been modernized and have been taken forward in different directions. And so in psychodynamic therapy, there is an emphasis on the patient-therapist relationship. And so it's much more common for people to sit face to face and for them to explore the interpersonal relationship in the therapy room as a way of understanding external conflicts, conflicts with parents, conflicts with people at work. Those can be explored in kind of an experimental condition of the therapy room. And in psychoanalysis, in Freud's vision, change and improvement would occur via insight, whereas in psychodynamic psychotherapy, change occurs through the relational experience, or providing people with corrective emotional experiences. So if someone is depressed, having a relational and emotional experience with a therapist who tells you that you are loved and that you are encouraged and that you are not completely worthless, and experiencing something different, experiencing different emotions in the therapy room, is the kind of vehicle for experiencing clinical change. Next is the behavioral approach to depression. For some cases, it can be best to approach depression by just changing your behavior. So without even attacking the thoughts underlying behavior, in some ways, it's useful to just attack the behaviors themselves. And so from a behaviorist perspective, there's a focus on observable behaviors and outward expressions of emotions rather than inner thoughts and inner experiences of emotions. Behavior therapists often use classical conditioning, other kinds of learning strategies to help people with their depression or with other aspects of psychological disorders. They might use things such as counter conditioning. So when a stimulus is paired with something that is either aversive or something that is more helpful to kind of remove the association that would lead to negative outcomes. A quick example of this would be like exposure therapy. So, for example, someone who has a fear of rabbits, seeing a rabbit automatically elicits sweating or a fear of, or a feeling of wanting to run away from a rabbit. And then you have something positive or something that's naturally just okay, like seeing some milk and some cookies. That doesn't elicit that fear. By pairing the milk and cookies with the rabbit, you begin to be able to associate the natural response of being of enjoyment. You naturally enjoy milk and cookies when they're presented by themselves. So when you add the rabbit and pair those together for a long time, you begin to extinguish the fear of rabbits, so that when you see rabbits by themselves, you feel okay and aren't afraid anymore. So that would be an example of behavior therapy. Other examples of behavior therapy are applied behavior analysis. Really quickly, this is a form of therapy that is used most frequently to help children with autism. Why? Because many children with developmental disorders don't have the ability to effectively communicate everything that's going on in their minds. That would be done in, say, cognitive therapy. And so it's better to take a behavioral approach. Lastly, probably the most popular way of doing psychotherapy today is to combine the cognitive and the behavioral. So CBT, as is commonly known, cognitive behavioral therapy, which focuses on treating depression by changing the cycle between a person's negative thoughts and their negative actions, their negative behaviors. And so CBT kind of combines some of the topics that we've described earlier, examining both cognition, thoughts, as well as how those relate to feelings, as well as how those relate to behaviors. We often talk about an ABC model to reveal cognitive distortions, looking at the actions or the activating events that lead to negative thoughts, looking at the beliefs, negative thoughts that occur after an event, and then the consequences, the results of believing those negative thoughts. So, for example, in the case of Danielle, it could be, being benched for a soccer game. That could be the activating event for these negative thoughts. And then examining what thought she's experiencing when she's benched for a soccer game, or what thought she's experiencing after leaving the soccer game. And then examining the consequences. What are the consequences of having that negative mood? She's not able to study. She's not able to concentrate in class because she's thinking about those negative thoughts. And so breaking that cycle is the main thrust of cognitive behavioral therapy. In the next video, we'll talk about different treatment modalities.